We have as our next speakers a wonderful dynamic duo, both distinguished professors at CUNY's Hunter College and both associated with Harvard, and together co-founders of Physicians for National Health Program, which without which I think it's fair to say we would not be having this wonderful pursuit of health justice in the form of Medicare-for-All. We would certainly not have this conference, and so it's really great pleasure to have Steffi Woolhandler and David Himmelstein talk with us.
Hi, we're also primary care doctors, which I guess could be a conflict of interest. It's obviously not a financial conflict of interest. The other thing I probably should say as way of non-financial conflicts of interest is we have served as unpaid campaign advisors to the Sanders campaign, and we also have a close professional relationship with Elizabeth Warren, having authored several papers on medical bankruptcy with her. So I was actually an intern about 10 miles from here at Highland Hospital just a couple years ago, okay? But this is actually the chart of a patient who I cared for. He was a 59-year-old man, and he was in a motor vehicle accident. He had an open skull fracture, and he was taken to Kaiser, and he had a negative wallet biopsy. That is, no insurance card. Okay, so he was transferred to the hospital where I was working in an ambulance with bone and brain visible through his head wound, okay? When he got to our hospital, we diagnosed a C1 fracture, a neck fracture, which is very dangerous, but in fact, he did okay and went to neurosurgery and didn't end up paraplegic or anything like that. But 4 days later, Kaiser discovered they'd made this terrible mistake, that he was actually a patient of theirs, and demanded his transfer back to Kaiser, where he went. So the real point here is that if you are uninsured or mistaken to be uninsured, you get unequal care, right? There's unequal care for people who are underinsured, but then there's also overuse of services by well-insured people, and that's how we get such high costs. So there's a pretty, that's our problem, unequal care, and there's a pretty equal solution that you have the same coverage for everyone, and probably everyone in this room agrees. Okay, but there's this other problem as represented in this slide, and cardiac defibrillator is this device they put in your heart. It's got a lot of complications, you know, but if you were to have a cardiac arrest, it might stop it in mid-process, right? But a lot of complications. It turns out that a quarter of all these expensive cardiac defibrillators that are implanted in this country are what we in medicine say non-evidence-based. That means they are unnecessary and potentially harmful. A quarter of devices placed into your damn heart, okay? So we have a significant problem of overuse of profitable high-tech care like these expensive defibrillators, and an underuse of primary care, mental health care, and long-term care. And the solution for that, as we're going to argue, is you must eliminate the opportunities for profit. Okay. So even under a single payer, if you allow people to profit, you're going to get dangerous overuse of high-tech services and underuse of other things, perhaps. Okay. There's a third problem, and we've talked about this a bunch today. These are actually the results that David Himmelstein and I have developed over decades, most recently appearing in this month's Annals of Internal Medicine, where we look at administrative costs in the US and, in this case, Canada, and it turns out half of the entire cost difference between the US and Canada is excess administrative costs in the United States. Half of the total cost difference. So any reform that makes any economic sense whatsoever, that has any resources generated internally to improve care for the people who are not getting care now, has to capture these administrative savings. And as we're going to argue, this is really only possible through a single payer system. Okay, so as I just showed you, there are about 17.2% health spending squander in bureaucracy. You have to eject private insurers. You have to simplify the payment system. And you'd have to globally budget hospitals, something that David's going to talk about. Okay. Now, people in Canada and other countries do not get less medical care than we do in this country. They simply don't. Looking internationally, at the United States, people in this country actually get the same or fewer hospital days than folks in other nations where they have national health programs. When we look at physician visits on a per capita basis, people in this country see physicians less often than most countries that have national health programs. We are not getting too much care, and you probably know, we're certainly not getting too much routine care. And we're getting less of something that is sorely needed in the United States, which is better long-term care. The share of population receiving long-term care is much lower here than in other countries that are spending half as much as we are overall on health care. What we are getting a lot of is lots of insurance overhead relative to other countries, many-fold higher, these are on a per capita basis, than other developed nations. And I'm going to show you this slide. I think we're actually going to show you more than once, because in some ways this is the core of the problem of insurance overhead. Insurance overhead is only part of the total administrative waste in the U.S., but it is a big part. You can administer the traditional fee-for-service Medicare program for 2%, right? You can do it for 2%. We know it because traditional Medicare today runs on an overhead of 2%. But once you introduce private insurance, as was done by allowing private insurers to sell private managed care plans on the Medicare, in the Medicare program, you bump up that insurance overhead to 12, 13, or 14% or higher. These are GAO numbers, Government Accountability Office numbers, 13.7% overhead for the Medicare Advantage program. Okay, private insurance squanders money on overhead. Some of the numbers are even higher. This is from the first quarter of 2019. The SEC filings of these insurance companies, the SEC filings of our major insurance companies show overhead as high as 17 to 18% in 2019. Now, are our American private insurance companies just, somehow crazy and bureaucratic? No, private for-profit insurance everywhere. Everywhere you have this private, voluntary, for-profit insurance, the overhead is extremely high. So Switzerland private insurance has high overhead. Canada, Holland, France, Spain, all of them, when you have the commercial private insurance, overhead is high. They save money in those other countries because they don't give private insurance a very big role. And we spend a lot of time talking about this little role and that little role and that little role, all of which is important. But the main thing is you make sure that their role is tiny. And I wouldn't even let them in at all. If it was up to me, the Supreme Court is probably going to say we can't do that. But whatever you do politically and in your plan, you want to totally minimize the role of private insurers, because everywhere they go, they push up overhead and cause other issues, to be honest. Now, I'm going to talk just a little bit about the issue of profits. Profits are a big drain on our healthcare system. The largest profits are in pharmaceuticals, $73 billion. Insurance companies, 22.1. Of course, that I folded into the insurance overhead. But other profits, too, that are basically really draining the system, like supplies and equipment, for-profit hospitals who push up costs, distributors, wholesalers, lab, pharmacy, benefit managers, et cetera. Lots of profits being drained out of the system, money that ought to be going for care. And obviously, a lot of these profits show up as CEO incomes. These are annual incomes from 2008, which is just unconscionable that in a system with 30 million uninsured people, somebody else is being paid more than $100 million a year. So to summarize, the U.S. healthcare system does something that completely defies economic logic. Okay, completely defies the neoclassical view of economics. And we are rationing. We are rationing today because people are inadequately insured, they don't get care, they're sicker, and they die younger. We are rationing today, and we are rationing in the face of a surplus of medical resources, excessive spending, excessive procedures like defibrillators, empty beds, too many high-tech facilities. So we're rationing a surplus, and that's completely irrational and, in a way, helpful for us in the single-payer movement, because by rationalizing the system, we can actually pay for everyone and get rid of both the rationing and the surplus, right? Now, this job of rationing the surplus generates tremendous administrative bloat, obviously. If you're a hospital manager and you've got empty hospital beds up here and patients in the emergency room with no insurance that you're trying to turn away, that is a complicated administrative enterprise. And we have vast armies of registration clerks and billing clerks and financial managers, not just in the insurance industry, but in the hospitals and doctors' offices themselves, trying to manage this problem of rationing the surplus. When we looked at hospital administrative costs, and this is on a per capita basis, not per patient, per capita, the U.S. is spending more than $1,000 per capita per year on hospital billing and paperwork. So you don't just need to get rid of the insurance overhead, you need to simplify the system to capture those high administrative costs, capture that administrative waste, and turn it into patient care. Duke Medical Center, and I'm going to pick on them because researchers there did a very detailed analysis of the administration in that hospital. Duke Medical Center only has 957 beds, but they have 1,600 billing clerks, okay? So that's 1,600 people, most of whom would need to be repurposed for other jobs, and hopefully they can be repurposed to help provide better health care. But you are going to see, as the previous speaker was saying, there has to be loss of these jobs. These people may get other work in the healthcare system, other work elsewhere, but the administrative cost does in fact represent people, right? Cleveland Clinic, this is one of the funniest stories, right? Because, you know, the Trump administration is pushing that they have to post their prices. They're saying, oh, if the hospitals just tell you what everything costs, this is going to work. I don't know how. You go there with your heart attack, you're not going to look at the prices, right? You're going to post prices. Well, Cleveland Clinic and a lot of other hospitals oppose this, and they are suing the administration. They don't want to post their prices. But one of the things they wrote to CMS is, we can't post prices because compounding the complexity, we have many different payers and multiple different products within each payer. Specifically, we have 3,000 contracted rate schedules. We have 70,000 lines in our charge master, 70,000 different things they charge for, this much for a Band-Aid and this much for a penicillin shot, right? Thus, the number of data points needed to post our prices, just to put them into a spreadsheet, the number of data points is 210 million, okay? So you do have some sense of how administering and collecting based on this kind of complex system could just pile on that administrative waste and waste a lot of your hospital payment, okay? Something similar happens in physicians' offices. You know, certainly I used to run my own office. It was an administrative nightmare, to be honest, but it's $500 per capita, again, not per patient, per capita in the United States. And in Canada, they're only spending 1/5 as much. And again, picking on Duke, they said that when to send bill for one employed primary care doctor, such as myself, they're spending about $100,000 annually to send the bills, okay? We know this in our own practices. The doctors are going crazy because we have to spend all day entering data into a computer, documenting it for the billing, documenting it for this crazy pay for performance. It's a form of billing. Doctors spend twice as much time on their electronic health record and doing desk work as they do with their patients, okay? So patients get 26% of our time, and our desk work gets almost half of our time. And we hear a lot about physician burnout. Trust me, this stuff is burning us out. The sick patients, hard patients, social problems in patients, that is not what's burning us out. It's this paperwork. Further illustration, the EHR, the medical record that I use, the most commonly used medical record in the United States and also used in Canada. The lighter color is the number of keystrokes in the average patient chart that someone like me would have to enter in the electronic medical record in the United States. Light is the United States. Okay. Internationally, doctors are using 1/4 as many keystrokes. So my documentation requires 4 times as many keystrokes as documentation for the same patients in the same EHR, in the same electronic health record system in Canada and other countries. So a tremendous waste of my time, doctors' time, nurses' time, doing this documentation, which is sometimes called clinical documentation, but is actually just about getting paid. Bureaucratic costs in doctors' offices and hospitals act as a surcharge on the price of every health service. So when people say things like the price is stupid, the prices are so high in the U.S., prices are so high in doctor's office. There are many reasons for that, but one key reason is every price you see from a doctor or hospital includes a surcharge for their administrative expense. So how do we pay doctors? How many people in the room work in medical care and have to bill? Not so many. Okay. So there's a doctor in the United States would be dealing with hundreds of different insurance plans because all the different insurers offer multiple plans. There's extensive documentation requirements. You have to your office has to collect co-pays and deductibles, and doing things to patients like procedures pays a whole lot more than thinking and talking and communicating with patients, right? That's the way we pay for doctors in the United States. In Canada, as Danielle was saying, they're not perfect. We're not talking about nirvana here, but they do use a simple fee schedule covering all patients. There are no co-pays or deductibles for doctors, and procedures pay more, but slightly more than thinking and talking, not 3 or 4 or 5 times more as happens in the hospitals where I work. Okay. Canadian physicians' incomes, Danielle said she regretted she didn't bring this slide, so I happen to have it here, but the doctors in Canada are paid very well, thank you very much. The doctors actually do just fine. I know they have to pay their overhead, and these are Canadian doctors, but their overhead is so much lower that, in fact, these salaries are actually fine, Now, under Physicians for National Health Program proposal, we would allow fee-for-service payment for doctors, similar to what they have in Canada. We allow some sort of modified capitation where you're just simply paid some sort of per-patient fee. It only covers a doctor's work. It's not supposed to cover the hospital and long-term care. Or you could work within a globally budgeted institution where you just work and the institution gets a global budget and pays you a salary. Okay. Again, looking at how hospitals are financed, okay, we talked some about how doctors are paid, hospital financing. In the United States, there are per-patient payments everywhere, including in Maryland. They use the term global budget. That's not actually quite accurate, but per-patient patients everywhere. Capital payments and operating payments are intermixed, and you're going to hear from David in just a minute about why that's really a problem, right? Capital and operating is intermixed. New investment is actually funded from a surplus or profits generated internally by the hospital. So if you get $10,000 for taking care of a patient, you only spend $8,000, you have $2,000 left over to fund new capital investment. And you also we have a system that allows gaming to inflate the profits of the hospitals. I'm not going to go into that too much detail. Okay. In Canada, there's global budgets, there's separation of payment for capital. New investments are funded separately. New capital investments are funded separately by the government, and they've constrained or eliminated most opportunities for profit making. Now, when I open my email, every morning I get 2 or 3 advertisements like this, okay? Literally every day, someone is telling me that I could make more money and my hospital could make more money if we learned how to upcode, how to manipulate what we put into the chart to make the patient appear sicker than they really are so that we can get a higher payment from the insurance company or from Medicare. And I'm not exaggerating. Literally, there were 2 this morning when I opened up my email, okay? But what they can do, the way that Medicare pays hospitals is they say, we're going to pay you extra for sick people and a little bit less for a less sick person. And we use the diagnoses to determine how sick the patients are. But the diagnoses that are used to determine how much Medicare, how sick the patient are and how much Medicare is going to pay you, depend a lot on just choosing the right words. And as this is saying, if I just change my words on the same one patient, you know, just improve the words as I go along, I can get about $3,300 more for my hospital by doing this. So they're just saying by going from pneumonia to aspiration pneumonia and from CHF, which is just an abbreviation for heart failure, to acute on chronic systolic heart failure, which just means heart failure, okay? But by just changing those words, I just got my hospital an extra $3,300, okay? So I was working at a hospital that didn't do this, really. We were a little small public hospital, and we were sort of mission-driven or whatever. And then we got this message that we were in deep trouble because our adjusted Medicare mortality was 1.42. I mean, 42% higher Medicare mortality, that would be terrible, right? It's definitely an emergency. So the response of the hospital leadership was to take $500,000 and purchase the services of coding consultants. Some of these people send me these emails all the time, right? And the result was that the next quarter, after we got the coding consultants, our adjusted mortality was 1.01, basically absolutely fine, just absolutely normal. And the next quarter, we were down at 0.86. We had gone from worse than average to better than average, doing nothing but paying $500,000 to a coding consultant company. And by the way, the reimbursement rose $3 million. Okay, what did they do? Okay, they hire nurses who would walk around the wards, grab the interns, residents, and attendings, and if you wrote the wrong words down, they'd tell you how to change the word to make the patient look sicker on paper. So acute kidney insufficiency, that was a bad thing to say, but the nurses would come saying, no, rewrite it as acute renal failure. Magnesium equals 1.6, which, by the way, includes a lot of information, but no, that doesn't work. Hypomagnesemia, means low magnesium, that would get you the money, but magnesium 1.6 didn't. Again, delirium would get you the money, but encephalopathy would. So just by going around and chasing the doctors and getting us to change what we wrote, in fact, we looked better because we looked better from a quality point of view because everyone thought our patients were sicker, and we made more money. So this is what happens in an industry that's profit-oriented. Good guys finish last. I want to say I also work at a big teaching hospital, Mass General at the time. I don't work there anymore. But they already had coding consultants. They'd had those coding consultants there 2 years ago, 2 years before we experienced this. So, and of course they were getting paid more. But, you know, so it's just a message to good people, you know, and I think most of us are good people, right? Good people is, good guys are gonna finish last. You need to cheat. And if you are willing to cheat, you really don't need to be good at anything else. And this is from Banksy, the street artist, but I got a little sassy and put the VW thing on the sign. Okay, I think David Himmelstein's going to take it from here.
Just to acknowledge, it's really nice to be back home in a way. I, like Steffi, trained at Alameda County's public health care system, Highland General, pictured here, and learned almost everything I know about health policy back then before I was 30 and stopped learning. And among the things that I learned was that Highland wasn't poor because Alameda County didn't have enough medical resources. Highland was under-resourced because we had a system that directed resources to rich people, and in fact, we rotated through what was then the largest cardiac care service in Alameda County on Pill Hill at that time. And there was a 40-bed ICU that was 2/3 empty most of the time, and the doctors were trolling for patients. And at Highland, we cared for a far sicker population, and we had a 6-bed ICU that we were constantly triaging patients out of. So there wasn't a paucity of resources in our community. There was, if anything, an excess of resources, but they were distributed inappropriately. And in fact, what I learned, and with my fellow residents, we got mad at the private hospitals, and we looked at where their funding came from. And every hospital in this county received more than 60% of its total funding from public resources. And in fact, altogether, they got about 6 times as much public money as Highland Hospital got. So there was this very complex funding stream of public dollars that flowed through Medicare, Medicaid, the tax subsidy for private insurance, public employees insurance, and it hid the fact that public money was reinforcing unequal access to care. And we're used to thinking of our healthcare system as a largely private insurance healthcare system. In fact, 2/3 of the total funding for healthcare in our country, as Jim mentioned earlier, I think calling on research Steffi and I have published, that came out of that early research when we were residents at Highland. 2/3 of the funding is public. So we're funding care largely publicly, and in fact what this slide shows is that we spend more in public dollars than any other nation on the face of the earth, with the exception of Switzerland. We pay for national health insurance, but we don't get it. So that was one thing I learned at Highland. A second was that we can't allow for-profits into our healthcare system. And I learned that one night when I was an intern and admitted a patient who was so severely dehydrated that he died the next morning. He had come from a nursing home that was owned by a for-profit company. And when my resident and I went and we pulled the charts of all of the patients admitted at Highland over the past year with severe dehydration, we found that there was an epidemic of dehydration from for-profit nursing homes in this county, and that virtually no patient was admitted from a not-for-profit or public nursing home with that severity of dehydration. And that's been backed up by research, not just from our group, but by other groups throughout the nation. We kill thousands of people each year by allowing for-profit providers to exist in our healthcare system. But we should say that it's not just for-profits that misbehave. So Johns Hopkins healthcare system, for instance, sued thousands of people for unpaid healthcare bills. And it turned out that they garnished wages, and the wages of the people they most commonly garnished were the wages of their own employees. So they gave their workers lousy insurance, and then they sued them when they came to the emergency department for care. And why does Hopkins do this? And they're not alone. University of Virginia Hospital was ruining people right and left, and many others around the country. Another example, Mayo Clinic doesn't, so far as we know, sue people, though they may well, but they've announced publicly that they prioritize privately insured patients over Medicare and Medicaid. They do that because to succeed in our healthcare system, a hospital, whether not-for-profit or for-profit, has to have a surplus at the end of the year in order to invest in their new facilities, to modernize, to expand, and actually to create the infrastructure of the future of the healthcare system. And now I'm going to help you take your post-lunch nap because I'm going to talk about capital investments in the healthcare system. That's something that almost always puts people to sleep, but it's critically important. Now, there's part of what also goes on here. Our so-called not-for-profits are accumulating huge surpluses. They're acting like for-profits because our healthcare system says in order to succeed in healthcare, an institution has to have a surplus. It has to have the money to expand, modernize, and so on. So Kaiser made, well, $1.891 billion in profit last year. They didn't distribute that profit to shareholders. They kept it within the Kaiser system, but that's nonetheless a surplus over their revenues. And you see the other major not-for-profit systems, including Mayo, that had similar gains. And of course, part of what they use this for now is they've become large private equity investors, many of them investing in for-profit healthcare firms. So Kaiser has $5.8 billion in private equity investments. They are acting like for-profits because our healthcare system tells us they need to. Well, that's one of the reasons we say you need to globally budget them, but you don't just need to globally budget them, as I'll get to in a minute. You need to separate their operating payments from their surpluses. So don't pay them patient by patient, give them a single operating budget for the year. My hospital administrator can tell you on January 1 what we're going to spend, but he collects it Band-Aid by Band-Aid, aspirin by aspirin tablet in hand-to-hand combat with insurance companies. And as Steffi showed you, that's enormously expensive. We need to stop it. We need to fund hospitals the way we fund fire departments and public schools. We say, here's your budget. Now deal with it. We don't say to a school principal, how many homework papers did your teachers correct this week? And we'll pay you for each one. We don't say to our fire departments, how many home inspections did you do this week? We'll pay you for each one. We shouldn't be doing that to hospitals. We also need to eliminate the disparity in payments for patients. So the reason Mayo Clinic prefers privately insured patients over publicly insured ones is because they're more lucrative. And the reason that Kaiser refused that patient whom Steffi showed at the outset, who I actually cared for in the ED, was that Kaiser wasn't making money from that. Well, we need to stop that disparity that some patients are profitable and some aren't. Third is that we need to stop hospitals from keeping a surplus. Why is that? That's because Highland doesn't have a surplus, and that's why Highland had 6 ICU beds. And why the private hospital that had a big surplus had unnecessary ICU beds. Because we let the hospital decide what's built rather than saying, what does the community need? Now, in those days, East Oakland was a low-rent district. I know it's changed. But we need to put the facilities where they're needed, and we know the market doesn't do that. So we need to stop hospitals from keeping surplus, and we need to fund capital, fund the future of our healthcare system through separate, explicit planning mechanisms. Well, this is a quote from a paper by the head of the Blue Cross Research Department back in the 1980s when Blue Cross was a very different organization. He said, capital is the lifeblood of the hospital industry, and a hospital's capital investment decisions have lasting and extensive effects on the quantity, quality, and accessibility of healthcare services. Without capital investments, hospitals cannot replace or modernize outdated facilities, technology, or equipment. Well, that determines, as I've hammered on, where the future of healthcare is. Here's, one of the palaces we're building, and it also drives future operating costs. So the estimate that Blue Cross executive made was that the operating costs of capital expenditures and the increasing per capita consumption of health services caused by provider-induced demand raise long-term costs. For every dollar invested in capital projects, second-year cost increases on average amount to 30% of the capital cost. So you invest $1 in a new building today, next year you're going to pay 30 cents more for care in that new facility, because as Milton Romer, a distinguished professor at UCLA, said back in 1958, a hospital bed that's built will be a hospital bed that's filled. And that raises costs. Well, if we allow the market to allocate capital, we know, and I'm going to skip over the text here, that it makes for inequalities. This is the David Koch Pavilion at the Hospital for Special Surgery in New York. Each of the patient rooms there has a fabulous view of New York's East River. And of course, the flip side is an increasing number of our communities that utterly lack hospital facilities because they're not profitable enough. Well, when we allow not just hospitals, but ACOs, the new way of paying hospitals, to retain surplus, we assure what we call survival of the fattest and survival of the meanest. Steffi showed you some of the mechanisms used to make sure that you're a winner here. Data distortion, so one of our British colleagues observed years ago, Julian Tudorhart, the distinguished British GP, that when you start paying doctors based on data they themselves manufacture, that data has the quality of and accuracy of a tax return. So we should not pay based on that, and it raises costs, and it causes a cost to care, a care to need mismatch. Now, I want to turn from the way we pay hospitals to the way we pay HMOs and the role for capitated systems in our healthcare system. So Steffi showed this slide that Medicare HMOs have far higher overhead than the traditional fee-for-service Medicare program. And you'd think that you could not possibly compete if you have overhead that's 4 times as high as the overhead of your competitor. And yet, Medicare HMOs compete very, very well. So this is the curve of rising enrollment in the Medicare HMO program. And Medicare HMOs basically are an option. The patient can decide to select a Medicare HMO rather than traditional Medicare, and Medicare pays their premium. And why is it that they can outcompete Medicare? Well, they've learned something very important, and that is that it's a few very sick people who account for the vast majority of medical care costs. So each bar represents 10% of the population. As you go from left to right, you're going to more expensive. The most expensive 20% account for 80% of total health spending. If you avoid them, you collect the premium and you don't have to pay out any benefits. And that's in fact what Medicare HMOs do. That's called cherry picking. And they have a variety of ways of doing it. Initially, they put their sign-up offices on the second floors of walk-up buildings, and that discouraged folks from signing up. That was outlawed, and they've developed much more sophisticated marketing schemes. So Google now is a part owner of a Medicare HMO, and they know my pants size and whether it's increasing, and whether I have recently purchased incontinence products. They can tell you who is a winner and who is a loser and who to market to. Medicare enrollees cost much less before enrolling than those who stay in traditional Medicare. We know that Medicare HMOs do cherry pick profitable patients. They also get rid of unprofitable patients, so-called lemon dropping. So I'm told I don't have much time, so I'll just tell you there is a raft of data showing that sick people, unprofitable people, switch out of Medicare HMOs. They do that by having narrow networks. If you're healthy, you don't care if the top cancer specialist is in your network. If you have cancer, you do, and you want to switch out. They charge high prices for the drugs that sick people need, and low prices for drugs that mostly healthy people would need. And cheating, which Steffi mentioned for hospitals, is rampant in Medicare HMOs. They upcode vigorously. We know that again from a raft of studies. One of their new schemes is that they send doctors into the homes of patients who have no diagnosis within the last year, and therefore are not getting them increased premiums. And they send those doctors in not to help the patient, but to make a diagnosis that can up the premium. We know that they sometimes do outright fraud. They cheat on their quality scores and getting the interest. I'll flash these by to show you I have the evidence, but I won't go into it. You know, this cartoon, if you believe a free market insurance system makes sense, you know, well, of course, a parasitical middleman has to make a profit before I can be allowed to access health care. It's the American way. Well, ACOs do pretty much the same thing. That's the new piece of the way Medicare is paying hospitals and doctors. They're not allowed to cherry pick patients, at least not formally, though probably they find some ways to do it. But they do manage to get rid of high-cost patients. We know that from really a lovely series of studies out of University of Michigan in the last year. And they do that largely by ejecting their doctors. Again, we can discuss that if you like it later on. You know, I had early experience with this. I was a doctor for U.S. Healthcare, one of the first HMOs that realized that bribes were more efficient than threats to get doctors to comply. They got us to collaborate with them against our patients by finding us when our patients had more hospital days, more specialist referrals, more ER visits, more lab tests, and so on. And as a result, virtually my entire take-home income depended on the bonuses for cutting the utilization of my patients. And Steffi and I wrote about that in the New England Journal of Medicine, and there was a gag clause in our contract that said we weren't allowed to disclose the financial incentives in our contract. And I got this kind note from U.S. Healthcare shortly thereafter telling me I was no longer a participating provider. This cartoon, I think, apropos, in order to remain competitive in today's marketplace, I'm afraid we're going to have to replace you with a sleazeball. So if we allow providers to keep what's left over from their capitation payments, we have a similar problem with the hospital payment and allowing hospitals to keep the leftover from their fee-for-service payments. And I'm going to just very briefly touch on pay for performance, which has become all the rage. And there are 5 assumptions we've identified that have to be met in order for pay for performance to actually work. That you have to actually be able to measure performance accurately, which we have no way of doing in medical care. That individual variation is caused by variation in motivation. If I'm not a good doctor, it's because I'm not trying, and that money will make me try harder. That financial incentives will add to my desire to try harder, not distract from it. And that the current payment system is too simple. We need to make it more complex. And that hospitals and doctors who are delivering poor quality care should get less money. So Highland, if it's not giving good care, should get less money, not more money. I'll just say there's a lot of evidence that says that's not true. Don Berwick, who ran Medicare and Medicaid and is sort of the guru on medical care quality, said years ago, I don't think it's true that the way to get better doctoring and better nursing is to put money on the table in front of doctors and nurses. I think there's a fundamental misunderstanding of human motivation. I think people respond to joy and work and love and achievement and learning and appreciation and gratitude and a sense of a job well done. I think that it feels good to be a good doctor and better to be a better doctor. When we begin to attach dollar amounts to throughputs and individual pay, we're playing with fire. The first and most important effect of that may be to begin to dissociate people from their work. Predictably, all of the pay-for-performance initiatives in medical care have flopped. In fact, they raised the mortality rates of congestive heart failure patients when we gave incentives to get them out of the hospital quickly and keep them out. They stayed out, they just died out. Well, I'm just going to end with my favorite ad recent times about the sleazeballs we're dealing with and whom we need to stop. So this is an ad for a health insurance company that I was attracted to, Everett Prime. I'm an avid hiker and particularly enjoy the mountains. I thought this one might be good for me. But it turns out that what isn't covered is for those of you in the back, mountain climbing, injury received while practicing, exercising, undergoing conditional or physical preparation for such activity. So we need to simplify the way we pay for care, and we need to take profit out of care so that we neither distribute resources based on profitability, nor do we depend on the profit incentive to direct our care. And that means changing fundamentally the way we pay doctors and the way we pay hospitals. And I'll end by saying there are a variety of really bad ways of paying doctors and hospitals and no good ones. And if we think that we're going to get good work by incentives in our payment system, we are sorely mistaken. The best thing we can do is stop disabling good work and trying to get the payment system out of the middle of our work. So thanks very much.
Wonderful. We have probably take about 2 questions, and then we're going to break for about 10 minutes, and then come back for the last 2 panels, which will be on long-term care and how do we get from here to there. And then, of course, as I mentioned earlier, we have a reception to which you're all invited. So let's see if we have a couple of questions for David and or Steffi. Maybe we should go to the break and you catch these guys as they're grabbing their refreshments.
Question?
Okay, now we have...
Hi, Richard Quint from PNHP and a retired physician. A question for both David and Steffi.
Can you speak up a little bit, Richard?
Sure. The question for both of you is, I remember when the ACA was being debated, and there was a lot of discussion and concern about would we have enough providers to take care of people who are going to flood the new system or so-called system. Has that come to pass or not? And is that a concern we need to have when we ultimately have a single payer system, that we won't have enough physicians to care for all the people who are going to be getting the care they need? And physicians as a proxy for all healthcare professionals.
Okay. Well, interesting you should ask. Adam Gaffney and David and I did a series of studies looking at what happens to utilization when you have a universal coverage expansion. So we not only looked at other nations that have gone to 100% coverage, but we looked at big expansions in the United States, such as the Medicare expansion in 1966 and the ACA expansion in 2014. And there's not an explosion of utilization. You get more utilization from previously and underinsured people, but that is balanced out by small, almost imperceptible decreases in utilization by people who are previously well insured. And so the answer is you generally have enough doctors, you have enough hospitals, and you don't get these explosive surges in utilization that are very costly. The one little bit of problem that we had with the ACA was there was people had a little trouble finding primary care doctors, but that reflects a primary care shortage for the reasons we've talked about, where you underpay primary care doctors, maybe not absolutely, but relative to what other doctors are paid, primary care tends to be paid less.
Yeah, just to add, this was studied in great detail in Quebec when they instituted their universal coverage program in 1971. And what happened was that well-to-do people waited an extra 2 days for a well patient visit to their primary care doctor, and people with serious symptoms were far more likely to actually have a doctor visit. Poor people and previously uninsured people substantially increased their utilization, but there was virtually no crowding out of necessary care, even for the well-insured, previously healthy people.
One more question? See a hand in the back, get a microphone over there.
Hi, Stephen Vernon, therapist for single payer and PNHP. Yes, there's no good way to pay. But I'd like to see us talk more and more about fee-for-service, particularly, of course, for individual and small group practices. In the area, of course, in terms of quality improvement, rather than having the big administrative structures that we have to go into in order to deal with all the paperwork, et cetera, we have more time for our patients. So that's why I'd really like to see us as a group and as a grassroots movement be able to address that, because a lot of our practitioners that we talk to are really concerned about getting into that kind of reimbursement structure that is at Medicare levels or less.
Yeah.
I'm sorry, you said a number of things. Was your concern that the payment rate was going to be too low for doctors? Was that your concern?
That's true too, but the first point is, I think, more general to address fee-for-service, which is getting a lot of bad rap that it shouldn't be getting.
Okay. You want to take
Yeah, I mean, as I said, I think there are a variety of poor ways of paying for care, and I think the literature does not suggest that there are particularly better ways than fee-for-service. They have different downsides, and one needs to control the total expenditures on fee-for-service, as the Canadian provinces do. Essentially, the way that most of the Canadian provinces work is they negotiate with the medical association for a total payment that will be made to the doctors in the province in the coming period, and then set up a fee structure that achieves that payment level. And what we've suggested is that the total payment for take-home pay for doctors in transition remain approximately the same, and that there be negotiation that arrives at a fee schedule that sets the fees to achieve that take-home pay that basically says to doctors, you're going to stay roughly where you are, though probably there needs to be some downsizing at the high end of our profession. I would say more than probably, there certainly needs to be. But we've, from the first in PNHP, said that we are convinced that fee-for-service is fully compatible with a single-payer national health insurance system. My personal preference is for salaried practice, both for myself, and I think there are some advantages, but I also recognize there are disadvantages to that approach. We have said that within capitated and globally budgeted system that there should be no financial incentives for the providers based on the financial success or failure of that institution. So doctors in a capitated system shouldn't make more depending on the financial performance of the institution they're working for.
Thank you, David and Stephanie.
Thanks.